Hey, what's going on everybody? I am Dr. Caban and welcome back to the channel. I am a general surgeon and a bariatric surgeon in North Central Florida, and today I'm going to help you decide what bariatric surgery is right for you. If this is the first time you're thinking about weight loss surgery, I will suggest you watch my previous videos about qualifying for bariatric surgery and self-paying for bariatric surgery if you don't have insurance coverage. The next thing we need to quickly discuss is the 4 types of surgery that I offer. Most other bariatric surgery programs offer the same procedures, but you need to confirm that with your program. In the near future, I am going to be making detailed videos of each procedure, but for this video, I'm just going to give you a very short description. You can also find more details on my website, and the link is on the description below. The first procedure that I offer is the lap band. The band is a restricted procedure where a silicone band is placed in the upper portion of the stomach to limit the amount of food that you can eat. The average excess body weight loss is around 40 to 50%, and that average weight loss is seen between 2 to 2.5 years. Procedure number 2 is the sleeve gastrectomy. In this procedure, approximately 3/4 of the stomach is removed in order to restrict the amount of food that you can eat. The average excess body weight loss is 60 to 70% between 1 to 1.5 years. Procedure number 3 is the Roux-en-Y gastric bypass. The bypass has 2 components. The first component is accomplished by making a small stomach the size of an egg to restrict the amount of food that you can eat. The second component is bypassing 150 centimeters of the upper gastrointestinal tract by attaching the new small stomach to the small bowel. The average excess body weight loss is around 70 to 80% between 1 to 1.5 years. The fourth procedure is the single anastomosis duodenal switch. Just like the gastric bypass, this surgery has 2 components. The restricted component is accomplished by creating a sleeve gastrectomy, and the second component also creates a bypass. The difference is that most of the small bowel is bypassed except the last 300 centimeters. The average excess body weight loss is 80 to 90%. Between 1 to 1.5 years. In order to decide what surgery is best for you, we need to look at several factors. I'm going to quickly mention them here, but I'm going to give you more details throughout the video. We need to look at your weight loss goals, activity levels, eating habits, risk tolerance, commitment, medical history, surgical history, body composition, and what type of surgery. Is it reversible or not? So let's get started with weight loss. When I see a patient in my office, I always ask what is their goal weight, and we calculate the excess body weight based on their ideal body weight and their current weight. Excess body weight is the difference between the ideal body weight and their current weight. In my opinion, the best way to understand this is with a real example. So let's go ahead and do that. So let's go ahead and imagine a 65-year-old postmenopausal female that has a history of uncontrolled diabetes, high blood pressure, and needs a knee replacement surgery due to severe knee pain. For simplicity purposes, we're going to call this patient Debbie. She needs to lose weight in order to have her knee surgery. Her current weight is 300 pounds and her ideal body weight is 150 pounds. That means that her excess body weight is 150 pounds. Debbie has a daughter that 2 years ago had a sleeve gastrectomy and she did very well after her surgery. Her daughter is around 35 years of age. She was otherwise healthy before her surgery, and she was very active before her bariatric surgery. The daughter lost 150 pounds after her sleeve gastrectomy. So because her daughter did so well, now Debbie also wants a sleeve gastrectomy so she can also lose 150 pounds. The first thing we need to understand about this case is that Debbie and her daughter are 2 completely different patients. First, they have different activity levels. The daughter was very active before her surgery. The mom has severe knee pain and needs knee surgery. The likelihood that Debbie is going to exercise significantly after the surgery is probably minimal. Second, they have completely different metabolic profiles, not only because of the activity levels, but also the age and hormones. Debbie is postmenopausal and probably has significantly less muscle mass, and that affects her metabolism. Just because these 2 issues alone, the likelihood that Debbie is going to lose 150 pounds after her sleeve gastrectomy is very, very low. In my experience, a patient like Debbie will lose around 50 to 60 pounds after a sleeve gastrectomy on a good day. Not bad, but that's way short of 150 pounds that she has in excess. Devi, in my opinion, is better suited for a more aggressive metabolic surgery like a gastric bypass or a duodenal switch. These two procedures will put her closer to her goal weight, and they will increase her chances of her having her knee surgery that she needs. Let's now talk about activity levels. We talked about activity levels with Devi in the previous scenario and how that can affect the results of the surgery. But let's look a little bit further. If you are wheelchair bound or you have a significant physical limitation that will limit your ability to exercise, you need to be looking into more aggressive metabolic surgeries like the bypass or the duodenal switch. This is particularly true the older you are. Younger and more active patients that can do more vigorous exercise can consider a lap band or a sleeve gastrectomy. Success after bariatric surgery takes effort and time. Exercise is a big part of that effort. You need to put the effort if you want to lose a significant amount of weight after weight loss surgery. If you think that the weight is just going to melt away after surgery, let me tell you, you're completely wrong and you're going to waste my time and your time. In life, nothing comes easy, and that's also true for weight loss surgery. Next, we're going to talk about eating habits. We will go back to our patient Debbie. She is the typical overweight female that frequently skips breakfast and lunch, routinely eats dinner, and eats a snack before going to bed. But she's not a big eater. Because she's not a big eater, she cannot explain how she keeps gaining weight year after year and her diabetes is always out of control. This scenario is very common. I see patients just like Debbie on a weekly basis in my office. A patient with these eating habits is probably more suited for a more aggressive metabolic surgery like the gastric bypass or the duodenal switch. The lap band or the sleeve gastrectomy are mainly restricted procedures. They limit the amount of food that you can eat. So they tend to work better in patients that are big eaters, that they eat a large amount of food. For a patient just like Debbie that she eats small amounts of food throughout the day, a lap band or a sleeve gastrectomy is probably not going to be the best option. As you can see, we are putting all the pieces together to come up with the best surgical option for the individual patient. But you need to remember that every patient is different and you need to discuss this with your bariatric surgeon. The next factor we're going to look at is the risk tolerance. Every patient has a different risk tolerance. The patient needs to feel completely comfortable with their decision regarding the type of bariatric surgery they're going to have. In my career, I see patients just like Debbie all the time. They're more suitable for a more complex metabolic surgery, just like the gastric bypass or the duodenal switch, but they don't want to have any of those two surgeries. Some of them are scared of having a big surgery. Maybe they had a bad experience with some previous abdominal surgery, or they have a friend or a family member that had a bad outcome after a gastric bypass, for example. In that case, I am not going to obligate Debbie to have a surgery that she doesn't want. My obligation to her is to educate her so she can make her own best decision. Other patients are more risk averse and they don't care about having a bigger surgery. They just want to have the highest weight loss possible no matter the risk. The risk of bariatric surgery nowadays is low, but complications can happen after any type of surgery. I will do another video in the near future covering the complications that can happen after bariatric surgery, but for now, hopefully, this will make you think about the risk from surgery. How about we continue with the commitment? For all bariatric procedures, commitment is very important. You need to commit to a diet before and after surgery. And as we discussed above, exercise is another big commitment. Another big responsibility is the follow-up. A big part of being a bariatric center of excellence is the follow-up. If you fail to follow up with your bariatric surgeon, you are hurting their program. So please, please, please follow up with your bariatric program. For the lap band, the follow-up is usually every 6 weeks. We do this in order to adjust the band so you can start feeling some restriction. You will need to follow up this frequently for 1 to 2 years. This is something to consider when having a lap band. Are you going to commit to such a frequent follow-up? You also need to know that most insurance companies only cover a few lap band fills. After those initial fills, you need to cover the cost of the remaining fills. How about the multivitamins? You will need to take supplements for life. This is particularly important after a gastric bypass and a duodenal switch. If you're having a duodenal switch, you need supplements for life. You need to take a bariatric multivitamin. A Centrum or a chewable Flintstone is just not going to cut it. It's not going to give you the vitamins that you need. And yes, you guessed it, the specific bariatric multivitamins are going to be more expensive. So if you cannot commit to taking adequate supplements or you cannot reliably take them, then a gastric bypass or a duodenal switch might not be the best surgery for you. I can give you many more examples of this subject about commitment, but we need to keep going, otherwise this video is going to take forever. Medical history is up next. This is a big area to pay attention to when deciding what weight loss surgery is best for you. Older patients with multiple comorbidities are at higher risk than those with no medical problems. A patient with severe heart disease on the heart transplant list has a completely different risk profile than otherwise healthy morbidly obese patient. Most patients awaiting for a heart transplant are better suited for a sleeve gastrectomy. This surgery is simpler and quicker. A patient with severe heart disease benefits from shorter anesthesia times and less body stress. Patient with severe esophageal reflux disease should consider a gastric bypass. A gastric bypass is one of the best anti-reflux surgeries there is, but patients with mild to moderate reflux can still consider a sleeve gastrectomy or a duodenal switch. Patients with uncontrolled diabetes on very high doses of insulin are probably better suited for gastric bypass or a duodenal switch. There are many other things to consider in terms of medical history, but the most important thing is that you discuss all your medical conditions with your surgeon and how they can affect your outcome. What about surgical history? Multiple abdominal surgeries could be a big limiting factor. It really depends on what type of abdominal surgery and the experience of your bariatric surgeon. If you had several C-sections, a hysterectomy, and your gallbladder was removed, that most likely won't affect much. But if you had a car accident and had 3 open surgeries to correct injuries, you might have limited options. If you had surgeries that require bowel resections or that probably created significant scar tissue in your abdomen, then a lap band or a sleeve gastrectomy is probably the best option. Unfortunately, the surgeon won't really know how much scar tissue you develop until the surgeon is inside your abdomen. In cases like this, I usually tell my patients that we're planning for a gastric bypass, but depending on what we find in the operating room, they might wake up with a sleeve gastrectomy. Make sure you discuss with your surgeon all the intra-abdominal surgeries that you had in the past and how they can affect your surgery. Next up is the body composition. Not every patient is built the same way. Some patients carry most of the weight in the midsections, others have bigger legs, thighs, and buttocks. There are advantages and disadvantages to both. Patients with most of their excess weight in their abdominal region are usually harder to operate on because it's harder to get to their organs because of the excess fat inside the abdomen, but they tend to lose the weight faster than people with peripheral obesity. The opposite is the patient with more peripheral obesity. They're easier to operate on, but the weight is harder to lose. Let's pretend that we have a 550-pound female patient with a BMI of 70 and significant central obesity. She is probably not a feasible candidate for a laparoscopic gastric bypass. She is probably better suited for a 2-stage surgery. The first stage will do a sleeve gastrectomy, followed by a conversion to a gastric bypass or a duodenal switch after some weight loss in 1 to 2 years. This approach will be more feasible and safer to that patient, in my opinion. A similar patient with peripheral obesity could have a laparoscopic gastric bypass, usually with not much difficulty. Sometimes it's hard to distinguish this by just looking at the patient, but an experienced surgeon might be able to give you an idea of what body type you have and how that can affect your surgery. The last thing to consider is the type of surgery. Is it reversible or not? You should think about weight loss surgery as a one-time deal, but sometimes revisions or conversions are needed. Some surgeries are completely reversible. This includes the lap band or the gastric bypass. And yes, a gastric bypass can be reversed. It is not an easy operation to do, but it can be done. Other surgeries are irreversible. This includes the sleeve gastrectomy and the duodenal switch. Some patients make their decision based on their future possibilities. They want to make sure that their surgery can be reversed or that can be converted to something else. Others look at the present and put their 100% of their effort to accomplish their goal. Bariatric surgery is not an easy decision. It has risk, but it also has many benefits. I know this video was a little bit long, but I hope it helps you out and it makes your decision a little bit easier. Remember that if you have any questions or comments, put them down below. Smash the like button if you like this video, subscribe if you haven't, and I will see you on the next video.